but they will be posted on the Long-Term Care Integration Project website, along with a video and audio recording of this meeting within the next couple of weeks. So please feel free to take a look at the presentations and the recording at that time. You know, since we meet quarterly, we often have new stakeholders that join us for our meetings. So I'd like to begin each meeting with a very brief a little background on the Long-Term Care Integration Project so that everybody has an understanding about how the programs that we talk about during the meeting link back to what the vision of the Long-Term Care Integration Project has always been. Now, back in 1995, the state passed legislation, AB 1040, that allowed counties to develop demonstration projects to improve the delivery system for frail, elderly, and disabled residents. And it was in 1999 that our county's long-term care integration project, under the direction of Aging and Independent Services, was actually awarded over the years 3 planning grants and 2 development grants from the Department of Health Care Services Office of Long-Term Care to create a more coordinated, integrated service delivery system in this county. Our efforts with the Long-Term Care Integration Project began with a very small planning committee of about 50 that began meeting, and they started the process by looking at integrated service delivery models across the country and then identifying the best practices that might be appropriate here in San Diego. They all shared the vision of reducing the fragmentation of services across the full continuum of healthcare and social services. Now, that stakeholder group has grown from 50 to over 800 today, and it includes consumers, caregivers, advocates, their family members, healthcare, social service, and various social supportive service providers. Here you see the mission statement that was developed early on by the stakeholders, and that was to develop that comprehensive, consumer-centered, integrated continuum of care across all providers and settings that allows consumers individual dignity and to remain in the community, their homes, as an integral part of the community. But we've long recognized the need that with integrated system comes the need for funding that's pooled, not categorical, and that minimizes process and maximizes the resources. So how did we get to where we are today? Well, over the years, the long-term care stakeholders developed strategies. In 2004, we were designated an Aging and Disability Resource Connection through funding from the Administration on Aging. We were one of the first ADRCs in California, and you're going to learn a little bit more about our ADRC very shortly when I talk about our Care Transitions program. In 2008, we launched Team San Diego. With your stakeholder input in design of that training, it's a training that educates healthcare and social service providers about how they can work together as virtual teams. And then to complement Team San Diego, we received funding from the Center for Technology and Aging to also activate the consumers to establish electronic personal health record and engage their virtual teams through that tool. But you know, looking back at the roots and our origination of the Long-Term Care Integration Project, our vision was to create a fully integrated acute and long-term care system. And for many, many years, we worked on developing or building from our Healthy San Diego, which is the very successful geographic managed care model. And you're going to hear more this morning in the second half of the meeting about how we have the opportunity to realize some of what we envisioned through the dual eligible demonstration project. Now, as you see, we have a very full agenda, and I think Ellen referred to that as well. But I'm going to try to move through it as quickly as possible and allow lots of opportunity for you to ask questions, provide feedback and input. And hopefully we'll get you out of here early enough that you'll be within that 2-hour, 2.5-hour visitor parking. So, I'd like to start this morning by talking about care transitions. How many of you are hearing for the first time about the work that's been going on in San Diego related to care transitions? Well, good. Then I won't be telling you anything new, but maybe. You heard earlier, we were one of the first Aging and Disability Resource Connections in California. But how many of you really know what an ADRC is? Uh-oh, I have my work cut out for me. Well, the ADRC is a no wrong door for individuals of all income and ages to turn for information about local long-term services and supports and facilitation of access to those services. And as an ADRC, we provide 4 core functions through the ADRC. The first is information and assistance. When we established our ADRC, we built it on the infrastructure that we already had in place with the AIS call center. Because you see, that calls together 30 different programs with one phone number. And the call center has always been our gateway to programs and services for older adults and people with disabilities. So through the funding from the ADRC, we built up our capacity and our technology in the call center. And we also enhanced the Network of Care website to be the virtual component of our ADRC, a place where anyone can turn to get information through the service directory, for example, of the services and supports that were available. Now, through INA, we field thousands of calls each month through our call center. We also provide short-term service coordination through a number of programs here at AIS. And we provide options counseling, which is that one-on-one interactive process where we work with consumers to identify the needs and preferences for services, and then we link them with those services. In fact, we just are completing a grant that we received from the California Health and Human Services Agency to actually pilot new statewide training for options counseling and also for establishment of training for options counselors. The next core function of our ADRC is relatively new, and that is the delivery of evidence-based care transition programs. And that's really what I want to talk about right now. Let me give you a brief history on the history of our care transition programs through our ADRC. In 2010, our ADRC was awarded an ADRC Enhancement grant from the California Health and Human Services Agency. And among the deliverables for that grant was to establish a pilot care transition program, the Care Transitions Intervention, CTI, in partnership with a local hospital. So through an MOU that we established with Sharp Memorial, in August 2010, we launched our C pilot. And we continued that pilot through the end of December of 2011, at which point we had transitioned 183 highly complex, both medically and socially, high-risk patients. They were high risk for readmissions because of their chronic conditions. And through that pilot, we were able to reduce readmissions, thereby, overall, reduce healthcare costs. It was based on the success that we were actually having with the Care Transitions program at Sharp, that our San Diego Beacon community then funded us to continue the work at Sharp Memorial after our grant ended, but to also expand the Care Transitions program to Scripps Mercy and UCSD Hilton. And through that program, our focus has been primarily the uninsured or the underinsured. These folks tend to be very medically and socially complex. We launched our program at UCSD in December. At Sharp Memorial continued in January, and I believe it was in February that we launched at Mercy. We're learning a lot through that Care Transitions process. In 2011, to support our Care Transitions effort, we were also awarded a supplemental grant, one of only 5 in the country, through the Center for Technology and Aging, to diffuse technology into an evidence-based care transitions program. And through our Tech for Impact program, what we've been doing, engaging our care transitions patients in using technology to support health self-management. We help them to establish an electronic personal health record, to take responsibility for their health care and an active role in the management of their health care. And through that network of care personal health record to also establish and maintain an accurate medication list. We also engage them in engaging their virtual team of healthcare and social supportive services by granting them access to specific areas of their personal health record. For patients that participate in our CTI program, that don't have a computer but are really interested in using electronic tools, we provide a computer through the San Diego Futures Foundation and reduced cost internet. Now, it is based on the experience that we have had with our Care Transitions program that we were well positioned to apply for a new federal program that was released in April of last year called the Care Transitions, Community-Based Care Transitions Program, or CCTP. And you'll hear more about that very shortly. But since the CTI model, evidence-based project, is really the root of our care transition work over the last 2 years, I really want to familiarize you with what that model is all about. The model was developed by Dr. Eric Coleman out of the University of Colorado at Denver. And there is actually a Coleman Institute in Denver where this evidence-based program is supported and transition coaches are trained and certified. You see, Eric noted that time and time again, fragmented care that patients were receiving as they were transitioning across different healthcare services, like from the hospital back to their primary care physician or to their specialist or home health or skilled nursing or even to home and community-based services, that this fragmentation was actually resulting in health outcomes and escalating healthcare costs. So he established this model, and it really took hold. And over the years, it's been tried and trued as an evidence-based practice in reducing readmissions for very high-risk populations that are chronically ill. So the CTI program is a 4-week intervention, and it's very, very much patient and caregiver centered, because the program is all about activation. It's about activating the patient and the caregiver to take the lead in healthcare and empowers them to make informed decisions. Now, the patients are supported by a transition coach, and our transition coaches, we have 3. They're all certified. As a matter of fact, we have a master trained coach who is certified by the Coleman Institute to train and certify other transition coaches. And all of our transition coaches are nurses, they're PHNs, but they also have experience in long-term care services and supports. And because they're employed by the ADRC, they have the ability to refer patients back to the ADRC to be linked into long-term services and supports to stabilize those social support needs at home. I believe that that has been a real significant reason why the programs have been successful, is the link between the nurses, the coaches, and the long-term care services and supports. So here you see the key elements of the CTI process. It begins with a referral from the hospital staff. The staff decide who is appropriate to participate in CTI. Frequently that decision is made by the fact that they've had multiple readmissions or that they have a new chronic disease diagnosis and that they clearly need support but would benefit from this patient activation model. When the nurse receives the referral, she goes into the hospital room and she discusses the CTI model with the patient. She talks about the tools that are used for CTI, and then if the patient's interested, she actually enrolls the patient into CTI. At the same time, she engages the patient in using technology through the Tech for Impact program and offers them the opportunity to participate in that program as well. Then the transition coach makes a phone call within 2 days after discharge, and on that phone call, she addresses any issues or concerns that have come up since the discharge, but she also arranges a home visit. And that home visit ideally takes place within 48 hours after discharge. And that home visit is a lengthy visit that includes the review and the establishment and continuation of the personal health record, the establishment of a medication record after the medications have been reconciled with the discharge medication and education has been provided about the medicine. The patient's educated about their chronic conditions, and then they're activated, encouraged, and supported to follow up with their primary care physician and other healthcare providers within 7 days after discharge. Then the model includes 2 follow-up phone calls that usually take place at around day 7 and day 14. But keep in mind that this is, while there's maintenance to this fidelity of the evidence-based practice, there's always nuances. So at any time, the transition coach may be working with the patient to get linked into the ADRC, helping them navigate through the healthcare system, and certainly more than 2 phone calls are often conducted. Now the CTI model is really focused on 4 pillars, and there's goals for each of these pillars and tools that associate each one of these pillars. Medication management, of course, the goal is that the patient becomes knowledgeable about their medication and has a usable medication system. The patient-centered record, or the PHR, is used as the vehicle or the tool to facilitate communication with the healthcare providers, but also to ensure the continuity of the care plan across all providers. The patients are encouraged to follow up with the primary care physician because what Eric Coleman found is one of the greatest drivers of readmissions was the fact that patients weren't necessarily following up with their healthcare provider. The discharge plan said that they were to get an appointment or have lab work, but they weren't necessarily doing that. So they're educated about the importance of following that discharge plan and follow their healthcare providers. And lastly, the focus is on understanding red flags. Now that's the signs and symptoms that the patient might experience that is a warning. And they learn to respond to this warning early. and know what actions to take so that ED visits and rehospitalizations can be avoided. So now that you've heard about the CTI model and our care transitions experience, I want to talk a little bit about a new federal program called the Community-Based Care Transitions Program. How many of you have already heard of this program? Great. Well, back in April of last year, CMS released a solicitation under Section 3026 of the Affordable Care Act for $500 million in funding for communities to work together to reduce readmissions for costly fee-for-service Medicare beneficiaries. The goals of CCTP are to improve the quality of care, reduce costs associated with readmissions, improve the patient's experience across the continuum, and this be achieved through partnerships between acute care hospitals and community-based organizations. Now, CMS said that you really need to target those most costly high-risk fee-for-service beneficiaries, and so they tended to be those with multiple chronic conditions, including CHF, AMI, pneumonia, or had other factors that resulted in them being anxious for readmission. Now, CMS called out in their solicitation that there were two preferred applicants. The first was community-based organizations that had been funded by the administration and CMS to pilot care transitions programs. And as you've heard, AIS, through our ADRC, had been funded to pilot and had received that funding from the California Health and Human Services Agency from the Administration on Aging. The second preferred applicant were hospitals who were on the high rate of readmission on the compare list. And in San Diego, we had two hospitals that were eligible to be the lead applicant on a proposal to CMS, and they were Paradise Valley and Scripps Mercy. The solicitation states that if CMS awards a proposal with funding, there's established a provider agreement. And so they agree to fund the community at whatever rate is negotiated for 2 years. And then funding in years 3 through 5 is dependent upon meeting performance outcomes. The solicitation opened in April of last year with a rolling deadline for submission of proposals. Last June, AIS approached all of the local hospitals, educated them about our pilot that we had had with care transition, and requested information about if there was interest in our community to come together as partners and put forth a proposal to CMS for the Community-Based Care Transitions Program. And much to our surprise, we received support from Scripps, Sharp, UCSD, and Palomar to move together as partners and to embark on a 6-month planning process to develop a proposal that represented the needs of this community together and submit that to CMS on behalf of San Diego County. This was a very large undertaking, as the 4 large healthcare systems in San Diego partnering with the county. It includes 11 hospitals and 13 campuses. Our planning actually began back in October, and we officially submitted the application on April 18th, and we are awaiting the decision from CMS. Now, I'm going to pass this along so that you're welcome to take a look at it. However, it is under armed guard, so there will be security checks at the door. Let me tell you a little bit about the planning process. each of the hospitals, which I've got to say are absolutely phenomenal. These healthcare systems had been working tirelessly well before we came into the picture on improving systems and doing innovative programs for reducing readmissions. So it was truly, truly our honor to have the opportunity to work with such experts. We learned so much from them. But each of the hospitals designated a team that would work with the county in the development of this application. We were also supported by the Health Services Advisory Group, which is the QIO for California. And they supported us so much in educating us about processes and collaboration, and they supported us with data. They had direct access to CMS data that we could use to do various analyses. We also had the outstanding pleasure of working with Dr. Joanne Lynn from the Alturum Institute. Joanne is one of the foremost specialists in this country on care transitions, and she was our medical consultant. There were times in which we felt like we were in different worlds and speaking different languages, and Dr. Lynn could translate for us. So I think she played a tremendous role in the development of this application. We also had a fabulous, absolutely fabulous grant writer, Valerie Nash. So how we began the process was that each of the hospitals completed a very intensive root cause analysis. What they did was they evaluated 2010 readmissions for Medicare fee-for-service beneficiaries, and they identified through these various fits why patients were readmitting to their hospitals. Then, based on the outcomes of that root cause analysis, each of the healthcare system identified both hospital-based and community-based interventions that could be implemented that would address very specifically those root causes. Then each of the hospitals established a blended rate. This means basically a capitated rate, where for them to deliver the hospital-based interventions to their high-risk Medicare beneficiaries, there would be one rate. The county also established their rate because we have a role to provide the community-based organization interventions. And both of these rates were rolled up into one rate, which was then presented to CMS. A very complex implementation plan was created, and we are in the process of establishing a learning and action network to really engage all payers and all providers to come together and work alongside of our CCTP partners to create and align processes for care transitions. We hope to host an event in the near future. So let's get down to the nuts and bolts of the care transitions proposal that was submitted to CMS. You heard me say that each of the hospitals conducted a root cause analysis. It was very interesting that although we have very different healthcare systems that serve very diverse populations, there were commonalities in what the outcome root cause analysis was. There were actually 4 common themes that emerged. The first was that the hospitals identified that there was inadequate or inconsistent continuity of care coordination and handoff at the time of discharge. And this was in the hospital systems. And so each of these hospitals have proposed that they're going to implement elements of 2 evidence-based processes, BOOST and Project RED. And Sharp, who's had tremendous success with their Bridges program, which is advanced care planning and transition to palliative care, is going to expand that program to reduce readmissions. The second common theme that emerged was that patients and caregivers lacked activation. What does that mean? It means that they didn't understand medication, they weren't taking the medications the way they were supposed to, they didn't have a handle on their chronic conditions, they didn't know what actions to take early. So all of those 4 pillars of the CTI model, that is what was not happening with many of these high-risk beneficiaries. The third common theme was that the medical community was doing an excellent job at the time of discharge, making sure that these folks had the durable medical equipment, the home health referral, the appointment with the primary care physician. But all of their efforts couldn't make up for the challenges that some of these folks were experiencing once they got home because they lacked social supports. Either they didn't have transportation to get follow-up appointments, or they didn't have any food in the house and no home-delivered meals, or they didn't have a support system and they went home alone and still had some functional impairments and certainly were at risk for falls or other complications. So it was really decided that there needed to be additional social supports for some of these real high-risk beneficiaries. And the fourth common theme that emerged is that some patients who were on very complex medication regimes or who had a history of non-compliance with medication or who just had were going home with complicated meds needed a pharmacist to actually go through this medication, reconcile those meds, and provide education at the bedside prior to discharge. All was said and done, and you see the proposal. San Diego did submit a proposal, a partnership between AIS, Scripps Sharp, UCSD, and Palomar, 13 total hospitals to serve almost 24,000 Medicare fee-for-service beneficiaries within this community. We pledged to reduce the number of readmissions by 20% per year, and I firmly we can do more. And based on the average cost of a readmission in San Diego, which you see is over $14,000, this will result in a savings to Medicare of over $12 million. Now this doesn't come cheap. We're requesting about $10.3 million from CMS each year to implement these interventions. We've requested an overall blended rate of $431.30. So when you think about that, that's a relatively inexpensive rate to receive the bang for the buck that CMS would get through implementation of this program. You might think, well, why on earth would CMS fund such a large proposal? Confident in saying that I don't think that CMS had seen a proposal as comprehensive as ours was. Well, there's 3 main reasons that we believe CMS should fund our proposal. One is because they really have the opportunity to learn about how they can scale up a large care transition program in a large, medically, socially complex population here in San Diego. San Diego has a proven track record of innovative programs. Our hospital systems have won numerous awards and national recognition. They have the prospect to test care transitions improvements in a predominantly managed healthcare market. A large percentage of our Medicare population in San Diego is already in managed care, and most other populations are in managed care now in San Diego. And many systems to improve care transitions have come from managed health. They've already developed their system, and their members have the advantage of having those systems. We are also providing CMS the chance to innovate with clinical and social service partners that really do want to work together, who share a vision, and have made a commitment to work together in this community across all payers to really improve care transitions for high-risk beneficiaries. Now, in just a minute, I'm going to turn this over to Stacy Berkey, who is the supervisor for our care transition coaches. And she's going to tell you about the CTI care coordination, or the enhancement of CTI through the provision of social supports that AIS has proposed to CMS. But do you have any questions? Yes?
I just have one about the grant application that was sent in the project.
Yes.
For, you said about 25,000 fee-for-service
About 20.
to Medicare. Does that, since Sharp is a partner, does that overlap or have any coordination with the Sharp, I think it's a Pioneer
the ACO,
who is going to be given 35,000 expensive fee-for-service patients to try and manage? Is there some connection there? Because now we're up to 50, that's about 50 then.
What we have understood from CMS is that the patients that are served through the Pioneer ACO do not have to be excluded from the Care Transitions program, because the Care Transition program is targeted at very specific interventions. And the intervention that's provided is based on the risk assessment and triage that takes place on admission. So at this point, and I'm sure we'll get more clarification from CMS on this, because Sharp is the first in the country pioneers ACO. So we'll be working with Sharp on that.
That sounds great.
Are there any other questions? Yes?
Is the $431, is that a per member per month?
It's not a per member per month. It's a per member or per patient that receives an intervention, whether it be a hospital-based intervention or a CBO-based intervention, or by both.
Regardless of how long it takes to make that happen?
Yes.
Okay.
The CMS has asked that the interventions be targeted within the first 30 days after discharge. So the interventions that would be provided would primarily take place within that 30 days post-discharge. Yes?
Yeah, I was wondering, with regards to the risk assessment being done bedside in the hospital, what kind of instrument are you guys using?
Well, each of the hospitals have their own risk assessment process that they will be undertaking or are already piloting. Many of them are adopting components of Project Boost and Project Red.
May I make a comment?
Sure.
It might be a nice objective in the future to have it standardized and validated, so you can really make sure that it's doing what you really want it to do. And by having 5 different ones or 6 different ones may not be the best way to go.
You know, and I think that as part of our proposal, we're establishing a steering committee with representatives from the key teams as well as the county. And there'll be lots of discussion throughout this process. We're going to look very closely at outcomes. We're going to be monitoring these interventions to see, are there some interventions that are more successful than others? Are there assessment processes that are working better to target these fee-for-service beneficiaries that are at risk than others? So this will be a learning process for all of us. But it's really important that we maintain the work that the hospitals had already begun. And many of them had already begun implementing redesign projects, or again, elements of Project Boost and Project Red, and had adapted them for their healthcare systems. Yes?
24,000 Medicare fee-for-service benefits, do they have Medicare only, or could they also have Medicare and a Medicare supplement plan?
they can have, as long as they're in fee-for-service Medicare. So they could even be a dual. They could have their Medi-Cal managed through managed health, but they could be in fee-for-service for Medicare. They just cannot be in a Medicare Advantage plan. Yes?
So the work that county's doing with chronic disease self-management?
So anyways, I've been involved in the pilot project and had the opportunity to be trained by Eric Coleman and his group in Denver, Colorado, along with our care transition coach. So when we had the opportunity to apply for the CCTP program, I was approached to, I guess, spearhead what we could do to enhance care transition intervention from a social service support view. So I worked with several people in our agency that have various experiences to come up with an enhancement model that I'll discuss briefly with you today. This is our flow chart that we came up with, and the care transition coaches in the hospital will be identifying people that are at risk socially for social support reasons. And we have a risk assessment that we're going to be using for them to do that, just so we have some uniformity within the referrals we're getting. So they're going to fill out this risk assessment to determine what people would be a good referral for our care coordinators or care enhancement specialists. So then they're going to pass along the risk assessment to the care coordinators who will follow up with the patients, hopefully in the hospital. You know, this all hinges on many things falling into place for each patient, but the care coordinator will be able to meet with the patients in the hospital. And we're going to have 3 levels of support or types of care enhancement. And the first one is assessment and referral. So those folks we're going to meet with in the hospital and, you know, explain the services and supports that are available, come up with a support service plan, give them referrals, and give them the support specialist or care coordinator's contact information. So those people are going to be just in need of some referrals at that point. And they're going to be able to follow up on their own. So there's going to be a certain percentage of people that we're going to meet in the hospital. We're going to be able to give them referrals, and then they have our contact information to contact with questions. The second level is the short-term care enhancement. And so again, the same process. They're going to meet in the hospital. They're going to discuss things, supports that patient may or may not have. And this also includes caregivers, family, whoever's involved. And so then at that point, it's determined the patient may have paperwork at home they're needing help with. They have different things going on. They're having trouble getting services in place, or they don't have any idea what the services are, and it's clear they really can't follow up with those immediately when they get home. So there may be home visits involved with this. There may be multiple phone calls that the coordinator would help them with, or the family, whoever's involved. So those people are going to be needing a little bit more support. And all of this, as Brenda said, is short-term, up to 30 days. That is also going to be if people are needing ongoing intervention, referring them to other programs that can provide that. The third level is the short-term care enhancement along with purchase services. So people that need some services in place when they get home, aside from home health. So some people might need transportation to doctor's appointments. We see that a lot. So taxi scripts, vouchers, or someone to actually take them to their doctor's appointment. Because some people know they need to go, they just can't get there. Homemaker, short-term homemaker. Some people, we see a lot of people that need pill boxes, they just don't have a pill box. home delivered meals, those durable medical equipment that isn't covered by Medi-Cal, Medicare, other ways. So we'll have those 3 levels, and how the coordinator will follow up is just going to depend on each patient. I mean, one patient may need 1 phone call, and there may be one that needs 7, and 2 home visits. I mean, so it's all just really going to depend. We'll have a support plan in place. We'll be communicating that with the physician, letting them know that we're involved, what we're doing, to loop the hospital back in, the discharge planner back in on what's going on, and keeping everyone apprised of what's happening with those patients. And then within the 30 days, at some point, if people, as I said, are going to need some longer term support than what we're able to provide in CCTP, we will immediately be looking for referrals for them, and with community partners and other services available within AIS. So that's kind of how the model looks now. That's what we put in our application. What it ends up looking like could be very different. We don't know how that's going to all play out. But this is what we've submitted at this point. We also have a small group of folks that go from the hospital to skilled nursing. And we were asked by one of the hospitals, they see a lot of patients coming back from skilled nursing. So there's a checklist that's completed before someone goes to skilled nursing to try to bridge the gap of communication sometimes that happens when people go from the hospital to skilled nursing. And then once people are discharged, those are short-term skilled nursing people. Once they're discharged back home, we would loop back in, follow up with CTI and with the care enhancement if appropriate. The hospital will be doing this discharge checklist, and then we have our flow on how everyone's part in that. So does anyone have any questions? Yes.
I do, because I was involved many years ago, in about 85, 86, in one of the Robert Wood Johnson Foundation coordinated care grants, and at the Mass General Hospital. And many that are being addressed in this were issues that we were looking at then. So a couple of the components of this that I wonder whether you thought about in this application or et cetera, really had to do with the fact that those high-risk patients who suffer from chronic diseases, and many of them are elderly, you have your initial 30-day period transitioning to home, and they're along those roads, and you do your assessment, and you go into the house, and it's all wonderful, and you make your referrals to all the other agencies. And then that level drops off. But in reality, the things that probably, I know that there's a period of time where people are vulnerable to bounce back.
Sure.
However, after that, these folks are still at high risk.
Sure.
And even minor changes in that care management plan puts them back in the system very quickly. And what I don't see in this model are those ways of communicating, because I know back then we looked at how could you integrate an outpatient medical or an outpatient record where the home health agency could write into that record, so that when a person is at risk or they're bouncing, there's more communication that either would prevent or when they end up in the emergency room, that's going to bring more information to bear so that that person may get back home more quickly. So I guess I don't see that component. And to me, that's the component that in the long run keeps those folks.
Are you talking about like medical records that people can pull, all the entities can pull that are involved? Is that right?
Yeah, so the home health agency could write into that record and say, this person's caregiver is failing.
Yeah, and that wasn't,
blah, blah, blah,
that wasn't a part of CCTP, community. That's why we're trying to link in with the doctors, and the care coordinator would link in with home health, whoever's involved. But the patient, part of CTI, the whole basis of CTI is making that patient the one that is able to be the communicator, if they're able to, because that's the whole reason CTI came about, honestly, because there's so many people involved in people's care at this point. The only one that remains the same is the patient or their family. So to have them be able to know and understand to some degree what's going on is the whole basis of care transition intervention. And that's why Eric Coleman came up with that model. Now, there's nothing to the extent of what you're talking about as far as the being able to get on a computer and type in communication back and forth. But the communication is really part of the key of why CTI came about.
Who are not as familiar, I do want to take you through kind of the project as it is. So what is the dual eligible integration project? Basically, here are the goals. He's come directly from the proposal from the state to the feds directly, coordinating state and federal benefits. The key issue, allowing people to remain home and out of facilities, is really the #1 goal. And right along with that is increasing access to home and community-based care, also now known as long-term care services and supports. One of the newer developments is ensuring that those individuals on in-home supportive services can continue to direct their own caregivers. So that's a recent development that's been proposed. And of course, we wouldn't be moving down this path if it wasn't also saving money. So euphemistically, we talk about optimizing the use, but just interpret that to mean saving some funds by integrating care, Medi-Cal, Medicare, and other resources. So sometimes people don't even know what dual eligibles are, because that word is used in other forums. Sometimes a person with mental illness may also have substance abuse disorders. We've called those duals for years. But in this situation, we're really talking about eligible for Medicare, parts of full scope Medicare A, B, and D, and Medi-Cal. Those are the dual eligibles in this condition. We have 1.1 million in California. And these are the oldest, the sickest, and the poorest people in our state that really need to be targeted here. They have chronic health conditions, and I think that's well known to many of you already serving this population. Now, we are the second largest. Those of you who are also working in LA, we fall way below what they've got in terms of targeting services. We have about 77,000 here, second largest county. One of the things we recently learned is the vast majority of the clients in our in-home supportive services program are duals. We never knew that until very recently. We have about 72% of our total 25,000 IHSS consumers that are duals. 71% 65, and I just read that only about 20% are currently voluntarily in managed care. So why are we moving down this path? The confusion, and how many of you here in this room are well aware, either with family members or people you're trying to help, trying to sort through the paperwork and who covers what. Medicare covers physician, hospital, limited skilled nursing, that initial entry, and rehab, while Medi-Cal covers the services. They cover personal care, in-home support, skilled nursing, and other services now covered by Medicare. But you have to know what those are, and the list goes on and on. Different payment rules, and it all adds up to a lot of confusion. I don't know about the rest of you, but when these type of mails come into my house, I stack them in a nice little stack. And I say, I'm going to get to that later. You know, the stack meal gets about this high, and I finally go through it. Well, some people know that they're never going to get through all that paper. It's highly confusing. And if the consumer has that kind of a problem, imagine how difficult it is to navigate the system. So that's the background, which, as Brenda was mentioning, we've really been well aware of this issue for many years and trying to figure out how we can address that through our long-term care integration project. A busy slide, but basically I just want to leave you with the issue that SB 208 was passed several years ago. It is the legislation allowing the state to move forward for federal approval for 4 projects here in the state of California. And those 4 have already been selected. I think many of you are well aware. LA is a 2-plan model. They have been selected. Orange and San Mateo, both county-operated health systems, they have been selected. And then frankly, we were surprised that we were selected because we have complexities with the geographic managed care system. We have 5 plans here in our region, 4 of which did participate and apply. Kaiser did not. And we thought, well, you know, just the complexities of having so many plans, we might not be in that first wave to participate in this demo, but we were. So, hey, that's great. And requiring stakeholder input, very important. We're going to talk a little bit more about how that's already started in our region. And one of the things that's happened already, and many of this, is the integration of seniors and persons with disabilities into managed care for their health. That started last June. That was approved in this same legislation. So here's just a nice little slide that I stole from the state, which I kind of like it. And it basically shows you where the geographic managed care counties are, where the county-operated health systems are, the 2 plan models. You can see that ourselves and Sacramento are the only geographic managed care, and the state contracts directly with the plans for Medi-Cal managed care. The 2 plan models, just what it says, county-operated health systems, they often have a county hospital, and they have a local public plan, and the 2 regions that have been identified, San Mateo and Orange, that's the situation that they're in. So LA is that 2 plan model. So why is the state doing this? We've been trying to get this initiative moving forward, and Bob Pratt remembers we've been involved for many years, but there was never any funding for the state to really support these efforts. And that's one of the things they repeatedly told us is, if we don't have money, we can't staff this effort and we can't really move it forward. But now they received $1 million in planning money, one of 15 states to do this. And the time is right now. All the states are working on this project right this minute. There were two models. There was a fee-for-service model and a capitated model. Our state chose for financing the demo the capitated model. So the contracts, for a long time we thought somehow the county was going to be a party to these contracts. We just weren't clear exactly how all this was going to work. But it was made very clear to us that the contracts are 3-way between the feds, the state, and the health plans. So that's kind of just a quick snapshot of what is happening, what's already been authorized, and how the financing would work. What services would be integrated in this project? It's basically everything that Medi-Cal and Medicare already covers, as well as, and this is the big one for us, long-term care services and supports, also known as home and community-based care services. Some of them are. Obviously, institutional long-term care is considered a long-term care service and support, but it's not a based care program. So some differences there. Personal care and IHSS, community-based adult services. Many of you are well aware of what's happening with that program. We are not here in San Diego, not formally moving our adult day health care in until October 1. Many of you are aware that deadline recently was changed. And the multi-purpose senior service program. I'm going to talk a little bit more about these in just a minute. Now, it's confusing here. First of all, there was the SB 208 that was already approved in law that allows the 4 demos to move forward. They were called pilots, now they're known as demonstrations. What the governor would like to do, and which is part of his budget trailer bill, is this coordinated care initiative. Many of you have heard about this. This would expand the sites from 4 to 8. And these other counties would come on board then. River, San Bernardino, Alameda, and Santa Clara. There were 2 others, Contra Costa and Sacramento. Those were put on the back burner for a later roll-in. And you would think, one of the reasons they dropped the word pilot is because this now impacts 685,000 out of the 1.1 million. That's no longer a little pilot. That now they're calling it a demonstration project. And I think that's why, just because of the scope of it here. Now, services were unclear. We had a meeting the other day, and we talked a little bit about this, and we said, we're not exactly sure what the timeline is here right now. We've been told it starts March 2013 through June 2013. Okay, that's a little hard to put your mind around, but That's basically what we're hearing right now. In terms of the start date, it certainly slipped off of January, and it may be as soon as March, some benefits coming in, or June. We're waiting to, and that's going to be one of our questions. Is there any more clarity you can lend to that?
A gentleman from HICAP, the head of HICAP here, said yesterday it's been delayed till June.
Okay, and that's one of the things that if you read the proposal that has been published that's gone to the feds, it has this language, beginning in March.
It
So
says
stay
no
tuned.
earlier than March and no later than June 1. That's the way
But
that's
I've
in the
also heard that it's
proposal.
Yeah, okay. So see, the rumor mill is happy. It's, you know, one of the, I said, being a little facetious, is why don't you just say July? Our fiscal year does not run like this. We start service July 1. Hello. But at any rate, anticipated savings has everything to do with that first partial year, 12-13, 663 million. This is state money only. It doesn't include the federal savings. 887 million in the second year of the demo. So that really gets people's attention. Cash-strapped state, I think, when you see these numbers. So the continued updates here, phased-in passive enrollment. In our region, individuals would be able to choose from the 4 plans we have available. And one of the real kind of sticky wickets here right now is whether or not the state can get federal permission to mandate enrollment for Medicare. And whether that can happen without changing federal law. We had a great expert with Julianne Howell working with HHSA, and she said that would require federal law change. So she said, I really don't see that happening. But the state continues to kind of talk about their desire to have that happen. So we're just kind of staying out of the discussion, but watching very closely to see what happens there. The proposed plan from the governor, though, and the last bullet point is, if the legislature adopts it, it will allow mandating all services by Medi-Cal in. So you could opt out with your Medicare, but your Medi-Cal, if you want to get long-term care services and supports, then you're going to have to get them through managed care. So just keep that in mind. It gets confusing, but this is what the governor is proposing. It's in front of the legislature, and then we'll see with the passage of the budget what happens. So there are some service carve-outs, and this is changing. The initial proposal had some different ones, and now the updated proposal talks about developmentally disabled waiver clients, and I know we've got a rep here from the regional center. They would still receive their IHSS through managed care, but their regional center services they would get through the regional center. Children, this gets confusing. They wouldn't be part of the demo. But if they're in Medi-Cal, they're receiving IHSS, guess what? Through the managed care plan. So PACE enrollees, end-stage renal disease, AIDS health. Then the waiver programs, it's a little bit of an alphabet soup. But initially there was talk about pursuing approvals to include the assisted living waiver, the nursing facility waiver. IHO is in-home operations. It's IHSS on steroids. There's more services. AIDS waiver. Many of you are familiar with that program. Assisted living. Behavioral health is the topic of a lot of discussion right now because the feds really wanted to see more with behavioral health. But it's very complex in our state, and there's a lot of discussion about how to really do that, you know. So right now, they talk in the proposal about coordinating services, looking for incentives for the county and for the plans on shared outcomes, keeping people out of the hospital, keeping them out of facilities, improving customer satisfaction. It may be integrated financially at a later. So this is really a big question mark. There's about 3,600 behavioral health clients that are duals. So it is of interest in our region. Other required elements, Part D coverage, Medicare, person-centered care coordination. I'm going to talk about these in just a minute. Coordinate and purchase supplemental benefits, and meaningful involvement of stakeholders. I'm kind of waiting to see if the state law gives more specifics about what that stakeholder really means, what it's really going to look like. So far, there's not a lot of definition around that. Uniform assessment tool. For those of you that have worked in the system for many years, you know that legislation has been introduced countless times to try to get uniform assessment. Never happened. But it looks like this is moving forward A year from now, a planning process will begin. This process will begin January 2015. Daycare, also known as community-based adult services, and then the 2 programs county currently operates, MSSP and in-home supportive services. That form will not be used for skilled nursing facilities, just for the community-based long-term care. And the plans are required to do a health risk assessment. This form will not replace that requirement. Now this is the county role. Again, this is proposed. The state law is pending. There's a lot of activity. Today is the deadline, but we've heard, there's a lot of discussion right now. I think it's got to be on somebody's desk today, so we've given it our best shot. We'll hope to see some of the things we've asked for in there. But in the proposed language right now calls for the plans to contract back with the county to operate certain services, and those are in-home supportive services. And it is very clear in the proposed law that the client would continue to hire fire and rescue. HSS was developed in the 70s. This is a core principle. This remains in the budget trailer bill. But the county social worker now does the assessments. That would continue. Public authority, Bud is our executive director, that they would continue to do what they're doing, a registry of available providers, training for providers, provider enrollment, background checks, orientation, screening, and payroll for providers. Then we operate the multi-purpose senior service program. It's a very sad state of affairs that we only have 550 slots for a county this size. That program is going to continue. However, as of January 2015, that program will become a managed care benefit. This is one of the areas there's not a lot of detail about yet, so we hope to be able to participate in planning for how that happens. One of the important things to note is plans can ask for additional in-home supportive services that they then would pay for. If they identify someone that needs more, the county has assessed, that's going to be one tool in their tool belt if they choose to exercise it to purchase more service to help that individual stay in the home. Person-centered care coordination has always been the cornerstone of this effort from our thinking. The health plans will work on identifying who needs it, and they'll do that through this risk assessment process, through reviewing medical records and encounter data to find out who really needs this kind of help. Not everyone will. One of the key things to note is that that individual will have a role in determining who they want to come to the table to help identify their needs. Interdisciplinary teams, including the care recipient. That will also include other practitioners, the healthcare providers, other social workers, community-based organizations, the county, to help identify the needs. And then the plans will be required to provide this. This is one of the core services that will be. Oh, let's back up. Supplemental services. This is an area that a lot of people are wondering about. Is there going to be funds available for the plans to purchase additional services? Or will the money just be sufficient for them to coordinate services? So this is a gray area. What it says right now in the proposal is that plans must build relationships with community-based organizations and partner or contract for services. 2 examples: home modifications, home delivered meals, additional benefits could be provided. And I don't know about you, but a lot of the people we serve, if they saw dental care provided, believe me, there'd be a big move to participate in these type of programs, because dental care is not covered for a lot of these folks, and it's really, really hard. Medical transportation, then some other areas such as care transitions, which we've talked about here, intensive case management. What it says in the proposal, this will become known as plans get some understanding of what money is available in the rate. So this is yet to be determined how this is going to work. Timeline. This is my favorite slide because I always have to redo it. Oh, this is not good. So I try to pay attention and get it right. April was when we learned that our community was chosen. The demonstration initial proposal released in April. May, we just saw May 31st. The proposal went to the feds, another comment period. I encourage you all to read it and send your comments in. We certainly will. June, July, the state is hoping for the feds to approve the proposal. They said a lot of their work over the summer is on this MOU between the feds and the state that will really govern how this project works. So they are optimistic, I think, to get this done over the summer months, but hey, let's, support them with that goal. Then November, December, initially there's readiness week to happen over the summer with health plans and the state, but I see that deadline is slipped to November, December, which is probably more reasonable because there'll be more knowledge about the rates, the financing. We still haven't seen the data released that shows Medi-Cal and Medicare data for the plans to look at so they can better understand, well, who are they going to be serving? And then the contract's completed in January, and we already talked about the March through June demonstration date. So that is the quick update for you. And I think it's a real exciting time. We just really enjoy the partnership we are building with the plans around this effort. Things are changing daily. We have to give a good shout out to Greg Knoll. We're going to talk about the advisory committee. And it's just a very adventurous time, combined with care transitions. We really have some excitement. One of the things I just want to leave you with is our director, Pam Smith, had shared, boy, it really seems like a lot at one time. And then we recalled that over 13 years we've been working in these areas on these efforts with many of you at the table. So even though a lot is hitting at one time, it developed over a lengthy period of time. And with your support, we'll be able to move this forward. So thank you.
Lisa, maybe we'll start.
Thanks. Hi, everyone. My name is Lisa Hayes, and I'm the Director of Disability and Senior Access Services. From
Lisa, you want to come on up?
No.
We'd love to see you as well as hear you.
I always look forward to Lisa being in San Diego.
Can I hide behind you, Brenda?
We're going to move George.
Sorry.
That's fine. I'll be glad.
I'm going to break your cords.
On the phone, that was Rogelio from HealthNet speaking. Who else do we have?
And I'm Andrew Whitelock. I work with government contracts with Molina Healthcare of California. I'm also based in our Long Beach office. And I work closely with ACAs on a number of different programs and initiatives. So I work with Medi-Cal and
Runs San Diego County for Care First.
Hi, if you could just put yourself on mute if you're on the phone, that'd be great. Thank you.
Excuse me, somebody on the phone, if you could please put your phones on mute, thanks. Okay, and I'm George Sclary with Community Health. I think we're all like one here, and I'm just going to speak briefly because I think there's going to be a lot of questions. Today we're here just to give you an overview on what we're doing as health plans, which is a lot. We're working every single day, 7 days a week. It's hard to keep up with all the meetings. It's really a challenge this time, probably more than the SPDs last year because there's so much we don't know. So a lot of the services provided by, through all of your programs, we don't know a lot about it. We know more than we did ago, but we don't know a lot about in-home supportive services and adult day health centers that are now CBASs. And so we have a lot of different work groups. To start with, they're state-mandated work groups that everybody's attending on a regular basis. Some of them are about behavioral health, some of them are about IHSS. The provider one Kim talked about. What were the other three, you guys, or two? Quality.
Performance standards that will be used to measure client performance and quality of care.
Separate work group in itself, all the health plans, that one in Sacramento. What else?
The financial, the rating.
Financial. Was there one more?
Long-term support and services is actually separate from IHSS.
So long-term
support. Right, there are actually 7 committees, and if people are interested, you should go to the calduals.org website, and as far as I know, you can still sign up for the committees even though they have that.
Yeah, because I know you can dial in, listen in,
right,
participate.
You get your own personal dialing numbers.
And the health plans are all in Sacramento meetings. I represent San Diego on the behavioral health one. We're just going to have our 3rd meeting coming up in a week and a half, I think, or 2 weeks. So we are doing stuff. Locally, we've done a lot, starting with getting to know our friends at AIS. This really started about a year ago, and thank God we became partners in the past. The Medi-Cal managed care plans didn't really work closely with AIS. These were services that we didn't know much about. We didn't know how the IHSS process worked, a little bit from Bud, because he's part of Healthy San Diego from day one, but we didn't know a lot. We knew what we needed to know. Now we need to know kind of everything, and it's really a challenge for us to learn it. So our focus lately has been on CBAS, community-based adult services. That becomes a Medi-Cal managed care benefit only down the road. We're trying to get the information out there and make sure that providers know who we are, what we do. Information gets sometimes turned around a little bit, like Scripps not partnering with health plans isn't actually the case. I know for my health, one of our primary partners, but it's the same for the other health plans, and same with UCSD and Sharp. But the word gets out there, and we need to start fixing that, because either way it's a problem, whether it's accurate information or not. And there's probably going to be more and more and more of it. So the best thing that's happened for us is that partnership with Aging and Independent Services. It's been incredible. From day one, we've had a great relationship with our county behavioral health system. We worked with them since mental health was carved out back in 1998. We have a team on conferences. We meet all the time. Right now, we're meeting a lot because mental health is going to be very, very complicated. There's two different benefits that need to look like one, but they are going to remain two different benefits. They're not all going to be carved in. The health plans are going to be the primary payer for most of the mental health benefits, and the specialty mental health plan, which is County Behavioral Health Services, is going to be the payer for those other benefits like case management, long-term lock treatment. There's only one in San Diego out in Alpine. We want to see where our friends at Optum Health fits in. That they handle the county's access and crisis line. So we are meeting on a monthly basis, and we are having 100 emails a day about stuff like that. So there's a lot going on. I think the first thing we did was when we did our RFS, Request for Solutions, that we all had to send in to Sacramento. One of the requirements was that each health plan creates an advisory committee. And they go, because of Healthy San Diego and how collaborative we all are, we said, why would we create 4 advisory committees? Why don't we just create one? And why don't we turn to the Long-Term Care Integration Project and say, you guys are the experts, you've been doing all this for 13 years, and there's all this information we don't know hardly anything about, will you be that advisory committee? And the answer was yes, and we formed our advisory committee, and we met, I think, 2 weeks ago.
May 24th.
May 24th, and the thing we needed to do at that meeting was elect the chair, and we were all very pleased that Greg Nall was nominated, and Greg Nall accepted that position. So I'm going to turn it over to Greg, and then I know we're going to open it up, and again, you've got health plans with a lot of expertise here, way beyond me, around the room, so we'll have plenty of time for questions.
Right. We'll actually ask representatives from the health plan to come up front and field your questions, and certainly the several questions that have already been asked. Great if we could have those answered during that process. Greg, thank you.
Sure, thank you for having me. You know, I was at the very first meeting 11 years ago of the Long-Term Care Integration Project.
13 now.
13. I was at the beginning, 1998, the start of Healthy San Diego, and I always thought back then never the twain would meet, and it was carved out of Healthy San Diego Geographic Managed Care, and now we're trying to bring it back in and integrate, and it's odd to say that I think it is an exciting time, as you guys talked about. And I see the light at the end of the tunnel, maybe. Just hope it's not an oncoming train. Maybe we can survive it. It is a very exciting time, but it's also a very scary time, because it's a time when we move forward with this integration. As you've heard all around the room, there are opportunities for failure. There are opportunities where consumers will be failed. We certainly have experience from the SPD population move, and we have tried to communicate all of that to DHCS, to CMS, so that we can get some changes made before the dual project rolls out. But as George said, the requirements for the health plans was to come up with an advisory committee, and we put together as many folks, stakeholders as we could. We have consumers, their advocates, all the health plans, the county, all represented on this advisory committee. The advisory committee had its first meeting May 24th, and the agendas for these committee meetings, and they're going to be monthly, are for the next meeting, work group updates, adequacy, stipends for consumers, board members, new members, and possible work teams. And the requirement of the advisory committee is so that stakeholders can provide health plans involved in the dual project with real information and real input regarding the major concepts that are going to move forward on program operations, benefits, the services, adequacy of the grievance processes, and consumer protections. All of that are going to be the driver for agenda items for the advisory committee. As my friend from HICAP noted on the phone, it seems to me that DHCS has not learned the lesson of the SPDs, and they need to quickly, because this is yet another very vulnerable population, a different population, and one that now brings to maybe 110,000 the number of very vulnerable people that are going to be moving in from a fee-for-service into a managed care environment. It is not that any of us believe you can't do this properly and you can't do this well, but you really have to keep the consumer in mind from the beginning to the end, and that is very much what I think a lot of this advisory committee work will be. We have talked to DHCS, not as the advisory committee, but advocates, along with health plans, around the possibility of learning from that group, SPD group, and having a 90-day transition period for enrollment. It takes about 90 days for the health plan to actually assess and get someone who they find on their birthday birth month is going to be their new patient or their new beneficiary. We think that the consumer should suffer during those 90 days. They should be able to continue with their same doctor's appointments, anything else that's happening, and that providers should be paid. It is a way to provide a smoother transition, because the act of enrollment, the day of enrollment, does not mean transition. There really needs to be time for the consumers. Also, DHCS has completely disregarded its own regulations for the SPD population around medical exemption requests. They set out rules for how that was going to work, and they've said, well, you got continuity of care. We're going to deny it. And so virtually, I'd say a full 80% of the medical exemption requests have been denied from San Diego providers. So the idea is, if you're going to have consumer protections, you got to stand up for them, you got to believe in them, and you got to make sure that they're adequate and appropriate. So those are some of the things that we'll all be working on. The consumer participation on the advisory committee, we plan to provide stipends of $50 per meeting, so that could be used for caregivers, for transportation, for whatever they need in order to be able to participate in that couple of hours each month. We're also very excited about the involvement of long-term care integration, AIS. I mean, if I ever have a proposal, Brenda and Ellen are going to explain it. I can't imagine me explaining it, because it would be complicated. But you guys are great about bringing stuff down so that we can kind of all grasp it, particularly if you haven't been involved in this for a long time, and I thank you for that. And they are involved, and relentlessly involved, thank goodness, on the advisory committee. Any questions about the advisory committee? Yes, ma'am.
Which organizations are represented on the advisory committee?
Well, right now, we do have a list.
Yes. It's over 40
yes.
different representatives.
We have dual eligible consumers, we have county behavioral health, we have IHSS providers, we have representatives of all the health plans, the Consumer Center for Health Education and Advocacy, United Domestic Workers, the Public Authority,
PACE, Senior Alliance.
PACE, AIS, Aging Services, ADRC, IHSS Public Authority, we said, Senior Alliance, CBAS, hospitals.
Regional Center, Access
Yes.
to Independence.
Community clinics?
Yes.
Yes.
Council of
Yes.
Community Clinics. Yes.
What about the professional societies?
Yeah, what about physicians?
Medical society,
We have the San Diego Psychiatric.
psychiatric, and the medical
And the medical
society
society.
have appointed members to the advisory committee.
Thank
Okay? Anything else?
Can anyone attend? Is that here?
I'm sure that they have to be open just like any other meetings that are sponsored through any kind of state and county involvement. We'd be glad if we got prior notice to make room available. Sometimes we're squeezed into meeting space with 40 people, but the only thing I can't imagine why they wanted me to be chair, except that I get people through meetings and out on time, even if it's 40. But you're welcome to come, and we do have some extra chairs.
And I would also be happy at this point in time, unless there's another mechanism that will be put in place by the advisory committee in the future, to field any of your questions, your concerns. Please feel free to direct those to me. I will then direct them to the advisory committee.
And I would be more than happy to ask that our list of members be given out to the Long-Term Care Integration Project membership.
Send that out.
That way, you have access to us, and if you want something on an agenda, if you want an advocate from the committee to be an advocate for your position, you can contact them easily and then ask that things be put on the agenda. We're going to have pretty full agendas until it's clarified, because as we've all, I think the one thing we've all agreed on is there is far too much left cloudy about who's paying for what, how much is it going to be, and when are we starting? So,
Clear as mud.
Anything else?
The current challenges that we have, and this goes across all health plans, is that hospice, when a patient is on hospice, and specifically if they're in a long-term care facility, the long-term care services then have to be billed through the hospice. The long-term care facilities can no longer bill direct to Medi-Cal. That's been a challenge today. And that's the way it is for fee-for-service Medi-Cal. And typically the Medi-Cal HMO patients have been retroactively removed from Medi-Cal once they were a hospice patient because of a variety of, I think, implementing that board situation. So today,
Disenrolled?
Disenrolled.
Disenrolled.
Retroactively disenrolled from Medi-Cal HMO and put back on fee-for-service. So today, we have the situation where the patients that are rolling onto service are on hospice, they have room and board, they're room and board eligible, when now the facilities are billing hospice for the services, we bill the plans. The plans aren't set up to pay for those services and don't think it's a hospice service. So there's been a big challenge on getting room and board payment for the hospice patients. Additionally, physician services or hospice physicians is another challenge, getting the plans to understand that physician services that are not hospice physician services, part of the hospice plan of care, but direct professional services are outside of the hospice benefit.
You say this is a problem today,
Today.
much less going forward.
Yeah, it's only going to, this is just going to now exacerbate what is currently a small problem on a small scale.
Can I answer that question?
Sure, go ahead.
Well, first, before I attempt to answer that question, I want to make sure that I'm very clear on what the situation is first.
Okay.
So from what I'm understanding is that you have a patient who is in long-term care, correct?
Correct.
And they've been disenrolled from Medi-Cal managed care, correct?
No.
Because you mentioned that it was retro back to Medi-Cal managed care. That's where I'm going to.
Okay.
Let me, one person at a time.
After we bill the health plan and the health plan discovers this patient is on hospice,
But they're in long-term care or in hospice? I want to make sure I'm clear.
both. A patient that's on hospice is eligible for long-term care, room and custodial care. So the plans will retroactively disenroll the patient back to when they came when they came on hospice.
They'll disenroll them once they're in hospice / long-term care, correct?
No, they can be in long-term care.
Well, no, hold on. This is what I want to make sure. Our responsibility for long-term care is only the month of admission and the month after. After that, it's enrolled into fee-for-service.
Is it automatic?
No, it's long-term care.
Yeah, it's not automatic. You
Well,
have to do
generally-
something.
Yeah, you have to do something, yeah. Generally
So-
For SPDs. For
So it
SPDs.
hasn't been automatically, it's been automatically done and then sometimes not automatically done.
Right, just depends on, it's case by case.
So we have struggled with getting payment for those room and board.
For the month of admission, the month after?
Yes,
Yeah, because that's our risk,
right.
yeah.
But none of the health plans are set up to pay hospice for those services. And according to the Medi-Cal regulations in the all plan letter, that's the way it has to work.
Well, it depends on the contract, from what I understand, it depends on who we're contracted with or not. Usually there's payment systems set up in place for that. We've had a long-time contract with several hospital providers in this county. There could be because of the line of business, it could be because of that, it could be because the contract hasn't been amended for Medi-Cal. It just depends on, that's a very specific question for a very specific area. So if you have a hospice contract, you should have a contact at the health plan who would be able to, you know that.
I know that.
Yeah, you know that.
I work for the
Right,
same
I know.
health plan you did.
Right.
The issue is that the systems aren't set up to adjudicate the claims. And the health plans, everyone I've spoken to, and I've gone all the way up to the state with several health plans, understand that now room and board has to go through hospice.
Can I just make, because we're hospice too, we have the same issue. There's the two components, we feel your pain. Because the way the traditional hospice program works, if an individual is residing in a long-term care facility or admits in to a nursing home for custodial care, exactly as you said, the health plan is eliminated. But unfortunately, the way the system works is it is a pass-through on the Medi-Cal room and board payment coming through the hospice. So where the health plan not used to at this point paying custodial room and board in a nursing home setting. So as we're trying to bill for the pass-through of the custodial room and board, many times the plans, we just went through this just a couple of days ago, they don't understand and even have a mechanism to recognize
Okay,
that
now I
custodial
understand the
room and board.
situation better. Now it's more
Yeah,
specific.
because you pay the hospice, we all have hospice
Right,
contracts,
exactly.
that's a hospice
Right,
benefit
exactly.
issue. This is a custodial room and board issue.
Right.
That is a mechanism of the system.
Right, well, we're gonna need to somehow look at that, and I'm not the person, but we're gonna need to somehow look at that specifically to see how we can have a fix on that.
Because
Right.
truly,
And
if
that's-
you go over it, it's
Yeah,
gonna
because
be-
now I understand the issue a little bit better,
Yeah.
now the way you've
So,
explained
and
it.
with that, as you roll out all these other benefits, how are your claim systems going to be modified to accommodate all of these other things that the current Medicare managed care does not pay for?
In one word, it's called development.
Buddha.
In other words, further developing the claim system.
Yeah, you're
That's
willing
what
to have to give
you,
it.
that's what you have to do.
Do you have all of their phone numbers?
I think they all know me except maybe one.
Well,
Yeah,
my point is,
it's
my point
an
is that-
individual case-by-case contracting issue, and we have our
Right.
legal requirements where we can't do too much contracting stuff, talking negotiations in a public forum.
Right.
So,
well, I would
as
never
long as
want
you
you
have.
to negotiate anything in
No.
a public forum.
And I know,
But-
or the other side.
But I'm hoping that they can work together. This is what I think advisory committees and what Healthy San Diego is trying to do. When there's a stakeholder that's got a problem and it's fixable, that we should be able to come up with a way, not just for her to fix it, but for the system to accommodate what you need.
As far as negotiating a contract, the Medi-Cal all plan letter specifically lays out how the plans are supposed to do it. So it's not as if individual contracts that we couldn't have the discussion across all health plans, because all the health plans are required to do the same and pay the same amount for those services.
And it's really based on the nursing home room and board. It has nothing really to do with us. It's set by the rates set by the state, like
Yes.
Correct.
I wonder though, under the federation, it might be easier.
Yes.
And
Maybe.
Maybe.
well, because
Or it
the
could be a
plan
lot
has
easier.
that risk.
Yeah,
and
Right
that's
now,
full
there's
risk.
hundreds of thousands of dollars that I'm fighting with health plans to get across all the 5 current managed care plans. So what I foresee is that amount just exacerbated into who knows how much, how many
And
dollars.
that's why this discussion helps us a lot. We want to keep looking at what's going to happen, how can we fix things ahead of time. So it's good. Good.
Glad you brought it up.
Definitely. And let me ask the two other questions, please, that were brought forward first before we field more questions. Lois, do you feel as though your question has been answered, or?
Well, I feel that I guess it's Lisa that said there's a meeting about this. Am I getting the wrong person? I'm saying that you're having some kind of a meeting to work with primary care doctors about their refusal to work with and recommending that to their clients to opt out of any kind of passive enrollment or that.
Yes.
I'd say in terms of answering your question, I appreciate that somebody's doing something, but the problem is huger. That's a terrible word. Is bigger.
No, it's a good word. It's the future.
That you can handle in a small group. Somehow the medical association, there's got to be a lot of buy-in to this to have people go in, because I see it as an access to care and continuity of care. I'll just give an example of a lot of population we have speak Farsi. There's only one Farsi-speaking doctor in managed care in San Diego, and among all the lists that we have gotten. Now, maybe I don't know.
There's many more.
Yeah, I think it's that
everyone that we have had contact with, and we have probably the largest Farsi-speaking population in our particular healthcare facility. And there's only one who is in a geographic area where the person can go. And and that's just one language. How many languages are we in San Diego County? I mean, Spanish obviously, but even Tagalog. But get beyond the big ones. It's going to be a real access to care issue. So I think I'm glad you're doing something, but I hope you have a lot of clout and a lot of power.
It's a statewide effort. It's not my clout.
And it needs to be a statewide as well as a countywide.
Right. And I just want to remind all of you that when you received the announcement for the long-term care integration project, there was a link to a survey. It's a 2-question survey asked specifically about what do we need to consider as critical services for network adequacy. And that information will be fed back up through the long-term care services and supports state work group. So please do go to that link and provide your comments. 2 questions only. Judith, you had a question that, boy, is one that I too have, and that is, without the Medicare benefit, really, is there a benefit to the dual eligible demonstration?
That was my question, but I think it's a question shared by nearly everyone in the room.
Yep.
And I'm not sure the plans are necessarily the ones that can answer the question. I think this is between the feds and the state as a determination of, how to make the program, what's the point of having a demonstration if you doom it to failure? So it's a much more universal that I wouldn't expect. They have opinions, I'm not sure they have answers.
Right. And I think that what we as stakeholders can do is continually provide that feedback to the state, which is in turn providing it to CMS.
Maybe another way of saying what I'm thinking right now is that since we are in this county are pretty committed to this project and want to see it succeed, I'm trying to point out something that I would see would not allow the plans to succeed, and more importantly, result in what we're trying to do, which is, the care coordination. So, if we put it into that perspective, it's all about being partner stakeholders in this, and I consider the consumers to be the stakeholders.
Absolutely.
And I don't see how it can work if that's the process that they're allowed to go through. That's no different than what they already have today, practically.
Yeah.
Exactly.
Yeah. I'm going to go to this question right here first.
Thank you. So the supplemental service on the slides, the home mods, home delivered meals, specifically care transition, is that something that you have decided across all the health plans, we uniformly will offer these? It's still in discussion?
Not yet. There's so much we have to do, so we're doing, honestly, everything we can as fast as we can, like all of our meetings. We have a meeting coming up with Regional Center, and we've been meeting with them for years. We're all real tight, but that's one of those things where we can't, we could spend the thing, but there would be no outcome because we don't know what's being paid for, we just can't do that kind of stuff yet.
With regard to that, I realize that amount of payment, what's rolled in there, and how the health plans can all individually afford to do all of the plans is going to be very important. But I think one of the things that can be the hallmark of this demonstration project is people, health plans particularly, to be extremely flexible in their thinking around what you're asking about. This idea that you want to save money and keep people out of hospitals and out of facilities. There's a lot of non-traditional ways to do that. And that includes building a ramp, things that may not be something normally the health plan would think of. I encourage that all of us try to think about how this money gets spent in a way that really works, the way Judith was talking about, which is coordinates the care, but keeps them out of the facilities and keeps them at home.
And if I could add, there is incentive for us to do that.
That's right.
We want to do that. And I think right now what we're all doing is really just trying to kind of survey and take what is here, who is offering what. It's really difficult to make any definitive things without knowing what the state or what we're going to get paid. But right now we're kind of in that process of, all right, who does what, what's available, what does this cost, and kind of just taking stock of everything. And we want to make sure folks stay in their own homes. That is definitely what the focus is going to be for us.
That's great.
How are you all going to identify the top 5% most costly patients in your group? Because, that's where all these programs break down, right? They try to apply to everybody what is in fact the reality. 1 out of 20 patients is consuming half, 10% are consuming 2/3 of the allotted economic, whether it's Medicare, Medicaid, doesn't matter. And we dealt with that at the Independence at Home Act, which started a week ago at CMS, which is 10,000 high cost Medicare, about half of whom are going to be duals. Found that was the critically difficult part, and how do you incentivize an in-home delivery system when providers typically don't pay house costs? So I was going to bore down. That's where the key to success is. Find the high-cost structure patients and get them to fund.
I'm sorry.
Yeah.
They should have a simple question. Doesn't CMS know that?
Well,
and like with the ASO that's going online, they're going to give them $35,000 of the most expensive.
But they're relying on you to do that, and they're relying on the ACOs to, in fact, do these as carve-outs because.
But they're giving the information. CMS says these are the ones you're taking.
No, you have to find these patients actually in a community and start these programs. Like the Chronic Care Initiative, where the down was, they made it a responsibility of the marketplace to aggregate the high-cost patients. We found in making house calls, you actually do that. We didn't intend to, but they all end up in our house call practice because they're too sick to get to the doctor's office. But the same thing would apply for chemotherapy patients. These patients are intensely doctor-specific. They're not going to be extracted. And since Medi-Cal never paid for house calls anyway, the point as to whether they opt out or
we identify them in a lot of different ways. It might not be the top 10%. We might want top 25 or 5, whatever. That hasn't been decided yet, I'd say. And it really starts with our health risk assessment, and then all the data that comes to us from both CMS and
is that an HCC scoring instrument, or when you say health risk?
It's a standardized form that we do, and like right now, none of us are really new at this. It's just the population is changing. We currently have programs right now, which are our dual programs, DSNP programs. special needs plans, which are all medis and stuff. It's just a smaller number. So, you know, like for my health plan, every single member receives an in-home face-to-face visit by a physician, not a nurse, not a social worker, but a physician, except the ones that don't want it. But, you know, so are we going to program? We're still working on all that kind of stuff. Most of it's being dictated on what the state wants and the federal government wants us to do, but a lot of it's, you know, kind of up in the air still if we decide on this larger population, can we all do those things?
I would just say, you might look at independence at home in terms of RTI did the implementation guidelines. If they'd be useful to you, because there was a lot of policy level discussion.
Information to help us.
Yeah.
Because we didn't, you know, we're being told we need to do this, and so we've got a lot to learn from you guys.
But the state actually today is going to provide to all the health plans de-identify utilization data, so we'll be able to see where the members for San Diego are going. Or they haven't been assigned, obviously, right, but we'll be able to get an idea how many are in in-home support services. The area that Medi-Cal is paying for, we should have today, and we're hoping to get the same information, a complement information with CMS within 2 weeks to a month. So we will know, and ultimately when the members come to us, they'll say, you know, Kim Fritz, here's her record. I have the state is going to provide, the state and CMS are both going to provide that. So ultimately we will know who, through our own efforts, but also through utilization data that they're providing to us.
You'll have the data, but you won't know.
Yeah. But one of the other things that we do is what George was speaking of is our health risk assessment was a state-approved assessment that we all submitted, and it's basically we stratify every single member based on whether they're high risk or low risk. So that's another way we can kind of see who are the higher utilizers, and that's really based on, you know, pharmacy claims, based on their, you know, open TARs, based on any you know, other date claims paid data. So we're not going in completely blind. We will have some, you know, ideas, and all of the high risk folks that we have stratified as that are the ones we are calling initially within the first 40 days.
30.
30 days. Yeah.
High risk for 30.
And then at that point, they'll assign a complex case manager, you know, working very closely.
Yeah, I mean, I know with our interdisciplinary care team, you know, we look at cases, and I'm part of that team, and I'm always surprised at how much our nurse knows about so many individuals, but it's because they were, you know, I mean, they name off names, and they'll say, oh, and the son called you yesterday, George. It's like, oh yeah, because I do mental health, and it's like, they do quite a bit. It's impressive.
And we're going to limit the questions now for no more than 10 minutes. Greg Knoll has a flight to catch, and I did promise to get you all out of here earlier.
Yeah, with regards to this, you know, that Dr. Banks was talking about, this whole thing is going to work, again, if the risk assessment model works somewhat well. And again, I keep on hearing, and I understand where it's coming from, utilization data. But what's really going to drive this is actually probably more off the psychosocial and support system than the utilization. So if you guys keep on talking utilization, you should get out of business because you're way off to the right on this. Okay? So you really, and I realize that you really identify some people